you so much for joining. So we'll look at hip pain today. Hip is a very wide topic, so we will try to limit ourselves to the topics that as the common topics rather than all the topics. And we look at different causes of hip pain. We'll basically it's an interaction to learn about the hip and what we can do for hip pain. And there will be, hopefully I'm hoping to talk for about 60 minutes, and then for half an hour we can have a discussion, and we can it's a two-way interaction then, and we can discuss and learn more from each other. So as I said, I work as a consultant orthopedic surgeon at Aintree University Hospital. I'm also a clinical teacher at the School of Medicine in Liverpool University. So coming to hip pain, we are going to look at the hip anatomy a little bit, the hip conditions, osteoarthritis, impingement, greater trochanteric pain syndrome, sacroiliac joint dysfunction, piriformis syndrome, stress fractures. Then we are going to do a little bit of hip examination, inspection, how to measure, palpation, range of motion, single special tests. Hello, Sarah Basin.
Hello.
Yeah, thank you so much for joining. We just started about a minute ago. Yeah.
All right.
You want to say a few words, Sarah? Or
yes, I apologize to everybody for being a moment late, and to welcome everyone, and to say thank you very much indeed on behalf of the college to George, because I know from past experience we're going to have a really enlightening talk this evening. So thank you, George, and welcome to everybody. Thank you, George.
Thank you so much, Sarah. Thank you for all your inspiration and your words, kind words. Thank you so much. So we're just starting off. So we were just saying that we're going to visit hip anatomy, hip conditions, hip examination, and some of the hip exercise and what the main exercises we do for hip osteoarthritis. So looking at the anatomy, we are going to look at the osteochondral first, that is the bones. So you have the pelvic bone and the femur, and they articulate through the hip joint, the acetabulum and the head of the femur. So that's the hemipelvis, the acetabulum or the cup, then the head of the femur, that's the ball, the neck of the femur, the lesser trochanter and the greater trochanter. The ilium, the pubis and the ischium, that becomes the innominate bone, or three bones together. So as a child, as we were developing, it was three different bones, but once we are an adult, it becomes a single bone and it fuses at the acetabulum. So it's three different bones that fuse at the acetabulum that makes the cup. Another difficult concept to understand is the hip has an anteversion, and I do not know whether this figure does the real justice, and hope all of you are able to understand anteversion. If you look at this axis going across, that is where the knee joint axis is. That is the femoral condyle and the tibial condyle. So this is exactly parallel to the body. But the neck of the femur is not parallel to the body, but it's an angle of about 8 to 15 degrees towards the front. Now that is there because the purpose of the leg is to push the body forward. So to push the body forward, it needs a vector to turn to the front. Ideally we need something vector directly in the front, and that is how it can push better. Ideally what we have in a kangaroo, it's got a tail, it's right in the center, it has the best thrust forward. But we are not a kangaroo and we don't have a tail. So we've got two legs. So because we have two legs, it needs to tilt a little bit or rotate a bit to the forward. That's how it can push us forward, and that is the anteversion in the hip. The next is the ligaments. Those are the structures that hold the ball into the socket. And then below that, we found the osteochondral part was the head of the femur. Then you have the neck of the femur, and then you have the extracapsular area, or the trochanter, the lesser and the greater trochanter. These are all the ligaments. You have the ligaments in the front is the iliofemoral ligament, and you also have the pubofemoral ligament. This is one of the Y ligament, the inverted Y ligament. As I've shown here in the pink format, this is the main one of the biggest ligaments, the iliofemoral ligament or the inverted Y ligament, the pubofemoral and the ischiofemoral. These are what holds the ball into the socket. Now there is a difference between the shoulder and the hip. The hip is like an egg in an egg cup, so its egg cup is quite contained, whereas the shoulder is like an egg in a saucer. it can move in multiple directions. That's why dislocation of the shoulder is more, and because it's like an egg in an egg cup, the dislocations in the hip is less. Then we come to the muscle, that is the final layer on the top. You have the gluteus maximus, which is the buttock muscle. Then you have the gluteus medius and the minimus. The gluteus medius is very important because that is the one that stabilizes the hip as we walk. It stabilizes the pelvis across so that as we walk, there is no drooping of the pelvis on one side. In hip arthritis, when there is pain in the hip, you have Trendelenburg sign. We will look at it later, but that's because the gluteus medius is not able to work. So even when we operate, we try to avoid injury to the gluteus as much as possible. There are deeper muscles. The deeper muscles include, in the front you have the iliopsoas coming from the spine, going down into the front of the hip and attaching to the lesser trochanter here. And these are the muscles in the thigh which also contribute towards the stability of the hip joint. Some muscles and also the neuroanatomy, because some of the nerves can get pinched between the muscle. Famous among them is the piriformis muscle, which is here at the back, deep down in the gluteal region, and that can sometimes impinge on the sciatic nerve and cause symptoms. In the front, you have the lateral cutaneous nerve of thigh, and that can get impinged and cause a condition called meralgia parasitica. We'll look at some of these conditions as we go across the rest of the presentation today. So the most important is osteoarthritis, where there is wear and tear of the cartilage, and the cartilage becomes weak and there is actually damage and you may have pain. So there is a 25% lifetime risk of someone developing symptomatic OA in people who live up to the age of 85, and there is a 10%. Not everyone who has OA requires a hip replacement, but current figures show 10% lifetime risk of undergoing a total hip replacement. Now this could be less if we exercise more and prevent osteoarthritis, but unfortunately that is not occurring. The incidence of hip replacement is increasing, but we'll come to what can be done for that in our conversation. One of the ideal tests to identify whether there is osteoarthritis is the Stinchfield test of the resisted straight leg raising. This is quite early on you can identify. You ask the patient to lift the leg up by 30 degrees by keeping the knee straight, and you push down the leg. And if they have pain in the front of the hip, then it is quite likely that they have osteoarthritis in the hip. This is one of the commonest tests to be done to identify if there is early osteoarthritis in the hip joint. Now this is an X-ray and you can see that there is osteoarthritis in the right side. There is point loading. Now if you notice very carefully, this is not a well-contained hip. Even this side is not a well-contained hip. It should be a little bit more inside. We'll come to that in a minute, what is known as a cam deformity. There is some dysplasia. There is point loading here. Over here you can see there is good cartilage throughout the hip, whereas here you can see the cartilage is worn out. This hip is actually subluxating outside. It's not contained within the cup. So that is why I say there is some deformity here, some dysplasia here, and that is why that this patient has developed osteoarthritis. Now this was very painful. Non-operative methods didn't work and required total hip replacement, where both the cup and the ball was replaced and the patient had a successful hip replacement. But not all hip replacements. 40% of the patients who are listed for hip replacements can avoid surgery if they do exercise. That's what research tells us. So we look at that later towards the end of the presentation. Now this is another lady who has a fracture on the right hip. She's also got some metalwork in her back. And we are looking at the left hip is the area of interest. You can see she's got again a little bit of subluxation. She got a valgus deformity. Ideally the hip should have been slightly here. So these are deformities which develop sometimes even in utero, or sometimes as we develop during the prepubertal, around the pubertal time. So in developmental dysplasia is if it may be a packaging problem. When I say a packaging problem, when the baby is in the womb, if there is not enough fluid, the hips are sort of crushed inwards, and when the hips are crushed inwards, the ball doesn't sit in the socket well. If there is adequate fluid in the mother's womb, the leg is not very tightly cramped and there is a bit of laxity, and the head of the femur sits well in the acetabulum and can recreate the acetabulum well. But if the mother's womb is tight and there is less fluid, then obviously the hip is more flexed because you're in that fetal position and the hip doesn't develop well. So there is a lot of relationship now to developmental dysplasia and developing osteoarthritis of the hip. So in this same lady, what has happened after some time, in 6 months later, you can see the hip is now damaged and there is no more cartilage. In the previous view, you could still see some cartilage, but in this view, the cartilage is completely gone. There are osteophytes here. There are osteochondral cysts. Cysts are forming. One of the signs of osteoarthritis, cysts is forming, and she has a hip replacement. But unfortunately, hip replacements are not successful, or not always successful. There are 10% of the patients who have hip replacements who are not happy with it. In knee replacements, 20% of the patients who have a knee replacement are not happy with it. So in this case, unfortunately, this lady had a dislocation, and then there has been subsequent further dislocations. So it is, an operation is good, but you need to do the operation only when it's absolutely essential, because there are potential complications, and once the complications arise, it is very difficult to correct them. Yes, there are other operations to do. You can do a revision, but it's like, it may be one failure after the other. So the most important thing is what nature gave. We need to try to preserve it and see whether we can use what nature gave originally without being replaced. But obviously, if everything fails, yes, a hip replacement is a good procedure. This another person had a hip replacement on the right side, and unfortunately there is a periprosthetic fracture, not seen clearly on the X-ray, but on the CT scan you can see the break. And then yes, a revision has been done and there is a much bigger prosthesis inserted. Now makes it more complicated. From a simple procedure, it becomes a more complex procedure. So we need to be careful, and it is not that operations are without its problems. Operations do have problems, so it is important that we are only resorting to a surgical intervention when no other options exist. Now we were talking about this development dysplasia. Sometimes the cup can be very shallow, and when the cup is shallow, there is the ball can move more, and when the ball moves more, you must understand this is the capsule or the joint capsule. The edge of the joint capsule, so the cup has an edge, and on the edge there is a lip, and that lip is called the labrum. Sometimes if there is an injury, it can cause a labral tear, like here, the lip maybe with a little bit of the bone can be taken away from the edge. So this is a labral tear, also called an impingement, and I'll tell you why it is called an impingement. Patients who have labral tear, the classical appearance they have is they put their hand here and say, that is where my pain is. So it's like a C-shaped. They put over the hip and say, yes, that is where my pain is. And that is one of the classical symptoms of a labral tear. So the labral tear is, as I said, a ball and socket joint. There is a lip to the cup and the ball sits within the cup. And when there is some injury, the ball can come out and pull the lip away from the edge of the cup, and that is what is a labral tear. But again, as we looked at, some of the developmental dysplasias called one labral tear can also cause the impingement, and this is where an impingement is. Now don't look at the rest of the images, just look at the blue image. Now this is the head of the femur, and this is the neck. Now technically it's like a lollipop. So in a lollipop there is a candy and there is a stick. Ideally you want the stick to be right in the center of the candy. But at times when we eat a lollipop, we will find the candy is not on the center of the stick and slightly to the side. So sometimes in developmental dysplasia we can get that, or in that is where an impingement occurs. So if you see here, the neck here but there is aspherical, there is excess bone here. So this is the cam deformity that can occur. In this situation, when the hip rotates, the edge of the acetabulum will hit this excess bone that is there on this side. So here, if there was a cup, as it comes here, it is likely to hit more on the neck here. So in a cam deformity can cause, so when that comes into contact, that is what we call as impingement. Now here we found the deformity was on the side of the femur, where the ball goes to one side and there is an excess amount of bone in the head neck junction. But it can be the other way around. It may not be the femur at all. The cup itself can be enlarged. It's like a egg cup, but the cup is slightly larger. The egg sits much more deeper inside. When the egg sits more deeper inside, the edge of the cup can also become more prominent, and as we move, it can impinge on the bone here and it can cause an impingement. But this impingement is called the pincer. The other one is called the cam type of deformity, whereas this one is called the pincer type of deformity, Pincer. So both this can cause impingement. Impingement is within the range of motion. It hits on the edge of the cup and it causes pain. So here we are looking at slightly a mild developmental dysplasia. The acetabular index is quite high. It should be less than 5 degrees. It is high, and there is an increased tendency for this hip to come out. And there's another measurement called the center edge angle. So center of the hip vertically up, then the edge of the acetabulum. This should be more than 20 degrees, but here you can see it's much less. So it looks as if this hip is going to come out. That will cause point loading here, and when there is point loading here, there is a chance of osteoarthritis increases. So it is in these situations that they need to be exercising earlier to prevent, osteoarthritis developing. Yes, it can be corrected. There are even operations to correct it. You can do osteotomy, periacetabular osteotomy, and correct this cup, but those are big operations. If we can avoid it, that is the best. Now, if you notice here, this is, as I said, the candy and the stick. You can see this is the stick, and the candy is not sitting in the stick, it is sitting to one side. And this deformity can be defined as called the pistol grip deformity. So if you put looks like if you superimpose a pistol, it looks like that here. So this, by definition, it's one of the ways of describing it is called the pistol grip deformity. So when you have a cam deformity, you can see the ball is not directly, the candy or the ball is not sitting directly on the neck, it's slightly sitting to the side. But this, I said, is the other type, the pincer type. There is more coverage of the ball, and there is, you can see the edge of the acetabulum has overgrown here. So this is the pincer type of deformity, and that same deformity may cause, a labral tear. This is the CT scan. And you can see on an MRI scan, there is a labral tear here, and there is fluid that is collected here in the same patient. So once there is a pincer, so it's part of the pincer deformity, excess coverage, edge of the cup is more, not just the ball is deformed, the edge of the cup is more, and hitting on the neck and causing inflammation and pain. So I've demonstrated here diagrammatically. Here you can see the pincer type of deformity where the edge of the cup has become larger and it can hit on the neck and cause impingement. Just a case study, a 25-year-old man with martial arts history. He's got pain in his 3-year history of right groin pain. And on examination, his FADIR test is positive. FADIR test is, it's an acronym, flexion, adduction, internal rotation. That's one of the signs that is seen in impingement. So you can see the hip is being flexed. So that's the flexion. Adduction, the whole thigh is being brought to the opposite side, that is adduction, and the lower leg is taken outwards, so internally rotating the hip. And this is an early sign of when you have an acetabular, labral tear, usually in the front. If you have a labral tear in the front of the hip, and this is positive, the FADIR test is positive. Just once more to show you the difference between the cam deformity. This is the normal bone. So as I said, it's a bit anteverted, but the neck and the ball sits right in the center of the neck. But in a cam deformity, the ball sits slightly off-ended. That's why it's called the cam deformity. This excess projection is likely to hit on this and cause. This is quite common. Pincer is less more common. It's not that the ball is deformed, the edge of the cup is more, and may happen in protrusio also, is slightly the edge of the cup is more prominent, and as it moves it can hit on the neck and cause an impingement. But sometimes you may get a mixed picture where both the pincer type of deformity and the cam type of deformity is there, and there is pain or impingement in the hip. An X-ray of an impingement cam type deformity, it's not sitting in the center, and yes, surgically you can remove this and decrease the impingement, that is surgically possible. Here you have pincer type where the edge of the cup is enlarged more, and as the hip is moving it can hit on the neck and cause a problem. The next condition we want to look at is greater trochanteric pain syndrome. Now, usually this is called trochanteric bursitis, but the current terminology is not to call it trochanteric bursitis, because it is not just the bursa. There may be various reasons. So it may be tendinopathy, it may be the bursa is inflamed, maybe the tendon is tight. So that's all together is the put together is called the greater trochanteric. That is how it's the more modern nomenclature is to call it the greater trochanteric pain syndrome. Now here there is a clear bursitis here. You can see this is the gluteal bursa. This is the MRI scan. You can see the pelvis here, the bladder, the head of the femur on both sides. This is the cup, the acetabulum, and the neck, and the greater trochanter. Over the greater trochanter is the bursa. The bursa is like a sac over prominent bony prominences. So this is the sac, so that it you're cushioned from direct contact. And you can see on the right side there is fluid in the sac, and there is trochanteric bursitis. So this forms a part of the greater trochanteric pain syndrome. But this is a very good article, and this is the most prominent trial for greater trochanteric pain syndrome. It's called the LEAP trial, LEAP, done in Australia for the greater trochanteric pain syndrome. So they had 3 groups of patients. So one group of patients, they just did exercises. This is a LEAP trial. The second group, they gave a steroid injection, and the third group, they just wait and see what will happen to them. That was the third group. And obviously the patients in the exercise group did better than the steroid injection, and obviously very better than the wait and see group. And you can see how the pain is decreased in the exercise program significantly, and this was statistically significant. So the exercises are good, and some of the exercise they did, I've shown you a few of the exercise in the next couple of slides. So these are trying to stretching the gluteus to the opposite side, weight bearing on both sides, doing a gluteal bridge, or the back bridge, supine bridge, then lifting one leg off when you're doing the bridge, and then single leg glute bridge by keeping the leg extended, then sitting backwards trying to squat with keeping the leg straight, then trying to stabilize on 2 legs, to stabilize on 1 leg, then single squat on one side, abduction, resistance abduction. Different exercises were done, and they found, but there are numerous exercises. The difficulty I have with this particular exercise is there are too many exercises to follow. When you give 20 different exercises to patients, they are unlikely to do it. If you give them 10 exercises, they are more likely to do it. More exercises, more difficult; less exercises, easy, and more compliance there. There are other exercises also for greater trochanteric pain syndrome. Here they are doing a mix of, this is not as big as the LEAP trial, but this is also a randomized controlled trial where they did both hip isometric and isotonic exercises, and there was reasonable benefit in both type of exercises. Again, here this is gluteal loading versus sham exercises. So I'm not saying there is only one particular exercise. Anything that increases the strength of the gluteal region has shown good benefit in gluteal trochanteric pain syndrome. So we all are, very commonly we find patients with trochanteric bursitis having injections, but that is wrong, because when you give a steroid injection, it weakens the muscle, it weakens the gluteus medius that is getting attached to the trochanter, and it can cause more problems. So it is best to do the exercise and have benefit. The next, we look at the sacroiliac joint dysfunction. Now, this is the spine, the lower end of the spine, the lumbar spine. At the very bottom is a wedge-shaped bone, that is a sacrum. That wedges into the ring of the pelvis. And on either side is a joint, and that joint is a sacroiliac joint. It has some movement, not a lot of movement like the hip, but a very slight jog of movement is there in the sacroiliac joint. But unfortunately, that is a joint that can get injured. It can get injured when you land, if you fall on ice or something, you fall on one bum, that joint can get damaged. It can also get damaged in car accidents. I see that occasionally. Say, for instance, someone is driving, you're pushing the brake pedal on one leg, the car is hit from behind. When it is hit from behind, and if say this right leg is on the brake pedal, the rest of the body twists to the opposite side. This leg is fixed because it is fixed between the brake pedal and the seat. So all the torque, it goes through the sacroiliac joint, and then that is how it can get injured. So sacroiliac joint injury is common in falls and also in road traffic accidents. This is how the tests that can be done. Sometimes it is very difficult to differentiate between sacroiliac joint problems and piriformis syndrome. So we look at some of the tests. So these are the tests for sacroiliac joint, identify sacroiliac joint. One is the distraction provocation test. So lie the patient down, put both the hands on the anterior superior iliac spine, and you're expanding, so the pelvis, pushing both the sides of the pelvis farther away, and pain in the sacroiliac joint region confirms, or at least points us that the pathology could be in the sacroiliac joint. The other one is the thigh thrust. So keep one hand underneath the buttock, the other hand cradling the patient's knee and thigh, and then you push down on the thigh down, and if pain is reproduced at the sacroiliac joint, then we can assume that the pain is coming from the sacroiliac joint. The third test is a Genslen's test. Here we are testing the right side joint, the right sacroiliac joint. So you lie the patient on the edge of the couch. The left leg is taken off the couch and allowed to hang downwards, whereas the other leg is flexed forward. So there is a stress on the sacroiliac joint on this side, and if that reproduces the pain, that is also one of the indications that the sacroiliac joint may be involved. The other one is the compression provocation test. Lie the patient down, push on both the hands, and yes, the patient will point to the side which is more painful. Is it the left side or the right side? In day-to-day practice, I find it very difficult. Lower lumbar pain, hip pain, sacroiliac joint pain, piriformis pain. This is very difficult. So more the tests to do, it's easier to identify where the potential pathology could be. But this is a very good test, the sacral thrust maneuver, and it identifies sacroiliac joint pathology quite well in my practice. So you take the heel of your hand and put it over the sacrum, and then you give a downward thrust. If the SI joint, which is on either side, is painful, they will point to that particular side and say, yes, this is painful. Again, what are the potential treatment for sacroiliac joint? There are multiple, but core-based exercises, lumbar core-based, where you're increasing the strength of the core, is quite useful for sacroiliac joint. Here they have different manual therapy, home-based, and a home-based program. All the three groups showed benefit. Again, this is a systematic review, and all their trials showed that core-based exercise, improving the stable core of the lower back, improved the sacroiliac joint function. Next is the piriformis, and all these places are not different. So that's why I say, whether it is from the lumbar spine, whether the pain is from the sacroiliac joint, whether the pain is from the piriformis, or whether the pain is from the hip, these are not very far away, and it is sometimes confusing to identify where is the pain. And quite likely even senior surgeons and doctors are mixing one with the other, and it is not easy. So the piriformis is a muscle that comes from the pelvis and attaches to the femur. But there is a relationship to the sciatic nerve. The sciatic nerve may come either through that muscle over the muscle or underneath the muscle. And unfortunately, the piriformis can compress on the sciatic nerve and cause sciatic-like symptoms, and that is what is piriformis syndrome occurs. But the way to identify it is to do some special tests for piriformis, and these are some of the tests. One is you ask the patient to lie on the side and abduct, lift the knee up. So it is keeping the hip in a bit of flexion, the knee in a bit of flexion, and ask the patient to lift the knee up. And at that point, you're pushing the femur down. So when you're pushing the femur down, they will complain of pain in the where the back of the hip or the piriformis, and that is one of the tests. You can do a similar test while they are sitting down. You ask them to sit down, and then they are trying to push their thigh outwards, and your hands are holding on both ends of the knee and preventing them from pushing outwards. Again, after putting that stress for about 30 seconds, if they complain of pain in one particular side, then potentially there is a piriformis syndrome on that side. But BT did some work, and he said you don't even need to push. You just ask the patient to lie down, keep the hip in a bit of flexion, knee in a bit of flexion, and lift the leg up, and within a minute or so you will have pain over the piriformis with the piriformis, because what happens is the piriformis gets hypertrophied and presses on the sciatic nerve. So you'll have pain in the back and pain going down the entire leg. So this is a narrative review, and it also shows some of the treatment. So you can do one compression exercise, but this is the typical piriformis stretch, whereby you're crossing your leg in a figure of 4, you're keeping your ankle over the other knee. Here, in addition to keeping that stretch, you're also keeping a roller underneath the buttock so that it can do a direct massage of the piriformis, but that is not essential. So this, which is a normal piriformis stretch, you keep a figure of 4 where the ankle comes over the opposite knee. Here you're treating the right side here, and then you can pull the left knee towards you, and as you pull the left knee, there is a stretch on the piriformis, and that is how you can decrease the tightness of the piriformis muscle. But again, as I said, these are all quite difficult to differentiate the sacroiliac joint problem and the piriformis. So the primary issue in the sacroiliac joint is the joint, whereas in the piriformis it is a muscle. In the sacroiliac joint, the pain may be higher up near the posterior superior iliac spine, whereas in the piriformis, it's deep down in the buttock. It's right in the bottom of your gluteal muscles. The pain in the sacroiliac joint goes only up to the knee. It will never go below the knee. And whereas in the piriformis it can go lower down, and it's quite common. The pain even to the leg pain SI joint is less. And that in SI joint, transitions, standing up for long time, sitting for long period. Piriformis, sitting for long periods or activity can induce pain. So people are quite more active in piriformis syndrome, like they are footballers or they are climbing steps or running a lot. So they all, because of the hypertrophy of the muscle. The next thing is stress fractures. Sometimes it's difficult to understand a stress fracture. On the left is a normal bone and increased stress. So this is how you have a normal fracture. When you have a huge volume load hitting on a bone, the bone breaks. That's a normal fracture. But on the other hand, in a stress fracture, it is multiple small thrusts. Yes, it is not enough to damage the bone completely, but over a period of time, the bone is reacting, causing new bone to form, and that is what a stress fracture is. Some of the bone is damaged and the bone is trying to reform to bridge that damage, and it is a constant cycle, but the amount of repetitive injury can cause this. We think only it may happen in elders. No, it can happen in a very young people too. I occasionally see, this is a young girl, she was only 24 years of age. Obviously, young women want, they want to look good, want to, maybe be thin, lose weight. So this lady was doing a lot of running. And unfortunately, when you do a lot of exercises, you can have amenorrhea also. That is, they will stop their periods. And when they stop their periods, there is no more drive to deposit calcium, because if you have no estrogen, there is no drive to deposit calcium inside the bone. And she came with hip pain. We did an x-ray and we didn't identify any problem in the hip. But then subsequently, when we did an MRI scan, you can see how there is a bright spot in the neck of the femur. So she has developed a stress fracture here in the neck of the femur by her excessive running. And on bone scan also, it is positive on the right side. We did a DEXA scan to see whether she was osteoporotic. She was not normal if the part is normal, whereas she was within the gray range, not fully osteopenic or osteoporosis, but she was not normal. So there was some deficiency in bone mineralization. And I'm sorry. And that is because of the excessive stress and the lack of estrogen in the body. This is a very interesting case. Quite some years ago, I've seen this patient, but we need to be very careful of this. This patient had severe knee pain, but he had no complaints in his hip at all. And this is X-ray of the knee, and you can see he's got a pristine knee, but his pain was in the knee. And unfortunately, he had an arthroscopy and everything. These are the notes which clearly says that he had, it's not my case, someone else's case, that he had, severe knee pain. And it looks shorter, and they were offered him a steroid injection, which he accepted. So they gave an injection into the knee. He was better only for a short period. Then they did an arthroscopy. Again, there's some placebo effect, but otherwise he still has, pain. So he was given an option of arthroscopy and washout of the left knee. So here they're giving him an arthroscopy. They also did an X-ray of his back to see whether the pain was coming from the back. There is some age-related changes, but nothing otherwise. Then they did an arthroscopy and they say there is severe arthritis. Though the X-ray was normal, they say the arthroscopy showed severe arthritis of the knee. But you must understand, arthroscopy is too, sensitive. I'm not being rude now, I'm just being factual. All of you brushed your teeth this morning. But if I take a microscope and look into your mouth, what do you think I'll find? I'll find a lot of germs. They are just normal. It is not abnormal to find germs in your mouth. So same way, if you take an arthroscope and look into the knee, you will think, because all subtle changes will look huge, those. So that is why they have described the significant arthritis. And he has now been listed for, he's got significant, they think he's got significant arthritis, and he's now listed for a knee replacement. So you can see here he's listed the patient for a knee replacement. But his knee looks pristine. That is his X-ray of the knee, and you can see he's got a consent form which says that he needs a knee replacement. But this is how the patient is standing. You can see knees seem to be straight, but there is some deformity in the lower spine and in the hip. And finally, when we took an hip X-ray, we can see there is significant arthritis in the hip, but he has not complained of hip arthritis at all, hip pain at all. His only complaint was knee pain. So, but it is very common, and this is in the Applay's book itself, it says that pain arising the hip joint is sometimes not always found in the groin. It can sometimes be seen in the knee. Pain in the seldom from the joint. It usually derives from the lumbar spine. So knee pain can masquerade. So hip pathology can masquerade as knee pain in adults, and we need to be very careful. So because both the knee and the hip are supplied by the same nerve, you can be that though they have hip arthritis, they may only complain of knee pain. So we got to be very careful, have a good examination, and that's when we can understand. So this was the patient. You can see that the left hip is shorter than the right. This is how he is standing. There's a definite deformity on the left side, and hip replacement solved his problem. Now looking a little bit at the hip examination. So you want to inspect, you want to see from the front, you want to see from the side, and you want to see from the back, and you want to see whether there is any muscle wasting, whether there is any deformity, whether there is any previous scars, whether there is any inflammation, but if all those are not there, then we can assume that the inspection is normal. Then we want to inspect while walking. Are they giving normal stance and swing phase. So it is a bit, I don't know whether we have looked at gait before, but as we walk, the legs go through the stance phase and the swing phase. So when the right leg lands on the floor, it starts the stance phase, then the left leg takes off the floor, that is the swing phase. Now we call the antalgic gait. The antalgic gait is where the stance phase on that leg is decreased, meaning the leg, both the right and the leg will spend the same time on the floor. But if you reduce the time on the right leg on the floor, then it is called an antalgic gait. So on the right leg, you're not keeping the right leg for a long time like in the left leg. You're quickly stepping over on the left leg. That is an antalgic gait. You need to palpate. You need to palpate from the front, the side, and the back to see where there is tenderness. You need to see the range of motion, inflection, extension, abduction, adduction. It could be lying down or on the couch. And you want to see the range of motion, internal, external rotation. But internal, external rotation is best checked when they are on the couch, either in the prone position or in the supine position. This is in the prone position. This is external rotation. This is internal rotation. So actually the foot is going outwards. It is the internal rotation. You want to also check how much there is lumbar flexion. But there are a few special tests in the hip. This is the Trendelenburg test. So the gluteus medius is holding the hip on either side. But if there is damage to the hip on this side, as when you keep says there is a damage on the hip on this side, as you keep the right leg on the floor and try to lift the left leg, the left hip drops down. And that is because the gluteus medius on this side is not, strong enough to hold the pelvis up. That is the Trendelenburg test. Here also is a Galassi test. You can see whether both the legs are of the same height or whether there is. I'll show you a classical example. This is a patient. You can see that the left leg is longer than the right leg. And you can also see the right leg is more externally rotated than the left leg. And this is how the patient is when he is flexed. You can see the left leg, that is the left leg, this is the right leg. The left leg is longer than the right leg. In the thigh part, the left leg is much longer than the right leg. You can see this is shorter. Now, why this is shorter? He has got a fracture neck of femur which he had ignored, and he's got a malunion of the fracture neck of femur with osteoarthritis. So if you take a CT scan, it shows how there is a significant osteoarthritis. There is the old fracture which has tried a malunion, and you can see there is point loading here, osteoarthritis with osteochondral cyst formation. This on the sagittal image, again you can see the cyst formation on the CT scan. One of the common tests we say is the Thomas's test, and Thomas is famous in Liverpool because he is from Liverpool. He's originally from Wales, but he was practiced in Liverpool. And the Thomas test, it was done in an era when there was used to be a lot of tuberculosis in the hip. And the Thomas test is to find out how much of flexion deformity is there in the hip or not. The way to do that is bend the normal leg to a point where the lumbar lordosis. So basically what happens is there's a curvature in the spine and there may be a deformity in the hip. Though there is a deformity in the hip, it can be covered because of the curvature in the spine, or it may not be easily seen. So you want to take away the curvature in the spine, and you do that by taking the good leg and bending it so that the curvature in the spine is lost. Then you see what is the residual flexion deformity in the opposite side, and that is how you decide whether there is a residual flexion deformity. That is the Hugh Owen Thomas test. Now in this lady you can see, it is very difficult. Where is the deformity? Is it in her spine? Is it in her hip? Very difficult to differentiate. She has had multiple surgeries including in the neck, but when she lies down, here you don't need to flex the other hip at all, but as soon as she lies down, it is clear that there is a flexion deformity in the right hip. We looked at this FADIR test in the when we looked at impingement. So that is flexion of the hip, adduction and internal rotation will cause early pain if there is impingement or early osteoarthritis in the hip region. There is also the FABER's test. These are both are acronyms. This one is flexion, adduction, internal rotation, whereas FABER's is flexion, abduction, the leg goes outwards, and external rotation. This shows if there is pathology in the sacroiliac joint or also pathology in the hip joint. So the very interesting part is coming to the hip exercise. What exercises do we do for hip, hip pain? Now you can see this is a study which shows why we get osteoarthritis. It is like the chicken and the egg. Which came first? Did the chicken come or the egg come? But quite likely here we see it's a muscle weakness that actually initiates. So the muscles become weak, and that is when osteoarthritis starts. So this is a common, metaphor that I give my patients. It's like my car tire. My car tire needs 40 pounds per square inch of pressure in the tire. If it is 40 pounds square inch, the shock absorbers last without a problem, as you can see in this image. Whereas if I don't put 40 pounds per square inch and only put 20 pounds per square inch, and if I drive the car will wobble a lot, and if it wobbles a lot, there's an excess strain on the shock absorber and they will, get damaged. Similarly, in our hips, in our backs, in our knees, if our muscles are strong, then there is no significant arthritis in the joint. But if the muscles are weak, there is more stress onto the joints, and that is how we get arthritis. So important to keep the muscles strong. Then also is a myth. We call it osteoarthritis. We call wear and tear arthritis. That is wrong. We shouldn't be calling wear and tear arthritis. Let me give you an example. Last summer I went cycling, and when I went cycling I fell down and I got a cut on my forearm. I came home, washed it in water and left it alone. And when I left it alone, in 3 weeks' time, it had healed by itself. So that's what happens in the human body. It heals by itself. There is a repair process. That same time, when I was reversing my car in my driveway, unfortunately the fender got caught in the pillar near the gate, and there was this scratch. So just like what I did with my hand, I gave it a car wash, left it alone, but it's not 3 weeks, it's now nearly 6 months, and the car has not got better. The car will not get better because this object doesn't have life, whereas our bodies have life. So in an inanimate object which doesn't have life, there is wear and degeneration. It's only a one-way process. But in a human body, there is a two-way process. There is wear and degeneration, but there is also regeneration and repair. So we cannot call our arthritis wear and tear. It's only in an object like this which doesn't have life you can call there is one way. So in our bodies there is a two-way. As there is degeneration and wear, there is also regeneration and repair. So we should not be calling our arthritis wear and tear arthritis. We should be calling it wear and repair arthritis, and that is what happens. So in healthy loading is good. Walking, a little bit of running, all these are good because that will allow us regeneration. So when we talk of that, we must understand unhealthy loading, lifting loads beyond our ability, running ultra marathons. 1 or 2 marathons may be okay, but running a marathon every other day or something to that effect is going to be harmful. That means you are causing more wear than what the body can repair. Equally, not doing any activity at all. So in this, someone who is a couch potato, spending a lot of time in TV, yes, there'll be the normal degeneration, but there is no ability to regenerate or repair because of the lack of physical activity. So the muscles are not going to be strong there. Now, if you are an animal lover, I would like you to close your eyes because the next few slides may be slightly, disturbing for you. So they did this experiment in Canada. They took some New Zealand white rabbits, and what they did in some rabbits, they injected. So one side they didn't do anything. On the other side, they gave Botox injections. So the Botox injection caused muscle atrophy and weakness of the muscle. Then they compared the normal side with the weakened side. And what they found, so this is the muscle, normal control where there was no injection given, good muscle fiber, but where they had got Botox injection, the muscle fiber has become much less, fatty infiltration is there. But on the injection where they gave the Botox, within a month, they found arthritic changes in the joint. So it is which comes first? Is it the chicken or the egg? In the hip arthritis, not the damage to the joint that comes first. It is the weakness of the muscle. So if one is able to keep up the strength of the muscle, it is likely that we can delay arthritis in that joint. And this is the work done by Professor Skoran Skov. He is in Denmark. He's done amazing work. And he has done a lot of work on exercises for hip and knee arthritis. And this is the research, one of the research that they have published. And in this research, they showed this was a large study, but 100 patients in this study were listed for hip replacement. And out of the 100 patients who had waitlisted for hip, only 60 required a hip replacement surgery. 40% of the patients did not require a hip replacement. A similar study, this was in Norway. They went through an exercise program, and again 44% they can reduce the need for total hip replacement. Only 66% required a hip replacement. The rest of the 44% didn't need. So good exercises can decrease the need for hip replacement. These are patients who have already been listed for surgery. So one orthopedic surgeon thought, or who the first orthopedic surgeon thought, that they needed an operation, was listed for surgery, but once they had the exercises, the need for surgery was decreased. This is again a similar study, again by the same group, Skoran Skov, and they found that if they do exercises, the painkillers are reduced. 52% of the patients with hip and knee arthritis exercise decreased the use of painkillers, and 18% stopped it altogether. Exercise is good painkiller, but yes, how to do exercise is important, but exercise is a painkiller. So the group in Denmark have started what is known as the GLAD program. The GLAD program is Good Life with Osteoarthritis Denmark, and they have done extremely well. From Denmark, they have now exported it to Australia. You can see all centers of people who are listed for hip and knee replacements in Australia are having the GLAD program. That has also been taken over in Canada, so there's the GLAD Canada. But unfortunately, such widespread programs are not available in the UK. Now, the basis of this GLAD program is what is known as proprioception. The common knowledge is that we have only 5 senses: sight, smell, touch, hearing, and taste. But we have another very special sensation called proprioception. Proprioception is joint position sense. So as I am walking, my left foot lands on the ground. When my left foot lands on the ground, it sends a million impulses to my brain on how the left foot landed on the ground. Based analyzing that information, the brain tells the right foot how to land on the ground. So that sensation when the left foot landed on the ground, what it gathered from the ground and sent to the brain is proprioception. So it actually 3 different parts. It looks at pressure, that is, what is the pressure that is being transmitted. It looks at the position, whether there is any movement front to side, whether there is any instability. And the last it sees is the rate at which the joint is moving. Is it moving fast or less? And this is a calculation. It doesn't come to a conscious level. It is on an unconscious level that the brain analyzes all this information. Unfortunately, as we grow older, we lose that. That is why old people who are older adults, they lose their balance and fall. So we need to regain back. And osteoarthritis also, people lose that, proprioception. So one of the exercises when we are doing for osteoarthritis, important to focus on proprioception, increase the joint position sense, because otherwise patients are going to find it more painful because of the instability. Whereas if we increase the proprioception, then they are more confident, then they will follow the exercise program very well. We learn proprioception when we are a baby. When we are born, we can't walk. At 6 months, we start crawling. Slowly, then we start standing and walking at the age of 1 year to 18 months. And during this period, you stand, you fall, you stand, you fall. But the body is learning that proprioception. Some people become very good at proprioception and they can do a tightrope walk. But we are not asking anyone to do a tightrope walk. It's very good proprioception. But unfortunately, as I said, older adults, as they grow older, they lose that proprioception, and that is one of the reasons why they may have falls. Now, this exercise program, the entire hip exercise program we have is called the Arise program, and it is there on the internet. You can see this is me giving you the program. I can send you the link for the hip arthritis program. It's exactly like the GLAD program, quite similar, but we have named it differently. So this is the backward lunge, and you can see not alone can you see the different, there's a demonstration. I'm talking about how the exercise is being done, how to position the leg at different points, and also there will be a video at the end which goes through the process. So it's quite easy, to understand and easy to follow. So we have called our program called the ARISE, and ARISE is A for awareness, awareness of the joint. So that's the proprioception. Resistance is against, so you use the weight and resistance to increase the strength. Our program is individualized to each individual, so that is the I. And S, you need to improve the core stability, so the muscles around the pelvis, the lower back, so increase the core stability. And there are some essential exercises like sit, stand, and tiptoeing, and that's how it forms the ARISE program. And we have this ARISE program rolling out we have done that. So if anyone of your patients has osteoarthritis or want to join the ARISE program, they're welcome to do it. And it very clearly says how, what I talked to you before, how it can get, it's because it's wear and repair and not wear and tear. And this is the book that comes with the hip pain. Thank you so much. Now I'll open it for discussion. Yeah, put up your hands. I can see there's already one question. You can raise your hands. I can admit you in. One second, it may slightly become unstable for a second or two. Give it a short time before it stabilizes. Yeah. Sorry, give me 1 second. Yeah, Jessica, you put up your hand. You can speak. Yeah.
Thank you. First of all, I would just like to say that was an absolutely fascinating talk, and I've learned a lot. I really appreciate it.
Thank you so much, Jessica. That's very kind of you. Thank you.
There was a question in the chat about
right, okay.
You can do exercises if you have bursitis.
Yes, you can do exercises if you have bursitis. Yes. Yeah. So the bursitis is now not called trochanteric bursitis. I mean, I'm assuming you're talking of trochanteric bursitis, but whether it's trochanteric bursitis or whether ischial bursitis, exercise is the solution. Now, I didn't go into eccentric and concentric exercises. Sometimes it may be eccentric exercises that you need. So concentric exercises when loading against weight. So if I take a dumbbell and if I bring my hand forward, that's a concentric exercise of my biceps. But if I take a dumbbell in my hand and slowly lower it down, that's an eccentric exercise of my biceps. So it is possible in some bursitis you may need eccentric exercises rather than concentric exercises. Yeah.
Thank you. Do we have any other questions?
Just please put up your hand. Please ask questions.
Any other comments? I think you seem to have answered their questions.
Did you all manage to see, hear and see all the slides, or were there any difficulties? Anyone can put up their hands and give us a... Yeah, Jessica, you can speak. I think you already have an ability to speak, I think.
Thank you. Yes, I hope it was okay. I took screenshots of the slides so that I can go over it again tomorrow. And
Sure. But there will be a recording anyway, and I'll put it on YouTube for you to see. Yeah.
Thank you.
But the slides you were able to see all the slides, and you were able to hear there was no difficulty.
Yeah, you were very clear and the slides were very clear.
Sure. Thank you, Jessica. Yeah. Anyone else? Any questions?
Deathly silence. I think everybody has found that extremely illuminating. And so.
Oh, Hannah wants to say, yeah, sorry.
Good. Hannah, hello. Unmute yourself. Well done.
Hi. I just wondered, I've had a client recently. She's late 60s and she injured herself trying to jump onto a moving treadmill. So her leg got taken quite quickly backwards into extension. And when I did tests, it seemed to say that indicate a labral tear. But my question was, at that age where there's probably some age-related changes as well, is a labral tear likely? Or I kind of always associated that with being slightly younger, like having more flexibility of the tissues.
I agree, but the mechanism which you say, because of the sudden extension, it is possible that there is a labral tear. But I mean, the real diagnosis can occur. But you must also understand it is a degenerate tissue. At 60, it's quite likely there is some age-related changes already in the capsule and the acetabulum. So it's very difficult. But she could quite possibly have a labral tear, an anterior labral tear. So, trying to do a FADIR test and seeing whether there is impingement is a possibility. But I don't think she requires any intervention for the labral tear. She just requires stability exercises, and quite likely it'll resolve by itself, is my, with time, with the right exercises.
So yeah, and she has had really good results with exercises. I had to have a follow-up with her next week, but yeah, she seems to be responding well, whatever it was that
Sure, sure, sure.
whatever she did. We did sort of conservative treatment before we did any kind of imaging because I thought with those exercises, if she got good improvement, that the imaging would be unnecessary.
Very true, very true. And I don't think we should do too much of imaging, because you're going to pick up age-related changes, and then people get very worried. There is a classical research where they did 100 patients who had back pain. They did an MRI scan. 50 of them were told the results of the scan. The remaining 50 were not told the results of the scan. And actually, a year later, they asked both these groups, how do you feel? The people who were told the results of the scan were psychologically affected, because they were all told they had degeneration in their backs, they had problems in their backs. So they thought their backs were very bad, but actually it was all age-related changes. Yeah. Yeah. Ajay, yeah, please. Yeah. Ajay, you can speak. Yeah.
You're
Ajay,
muted.
Ajay, I allowed you to speak. Yeah.
Oh, hello. Yes, I gained a lot from your presentation today because I did my training many years ago. And from your presentation, it seems like exercise is a very useful way to, do without operations. So, in our training, we weren't really taught a lot about exercise. So that was brilliant. I think I'll have to watch this presentation again because you shot through it. I mean, some of those slides with lots of text aren't really necessary. I think you could just give the titles because we don't have time to read it. And I always think I'm missing out on something. So you could give the titles, and some of the drawings and diagrams are a bit small.
Sure. No, I take your point. No, thank you, Ajay. That's useful advice. Yeah, I take on board the points. Yeah.
But that was very useful that, you could reduce the number of operations by 40%, something like that, wasn't it? Amazing.
Exactly. 40% in hip, and the needs nearly 60% if you do
Yeah.
proper. But the biggest difficulty is, how do we inspire our patients to do the exercise?
Yes.
That is the
Yes.
biggest, I wish I can find an answer to that. And if I find an answer to that, I'll get a Nobel Prize, I'm sure.
Well, I'm going to have to learn about, more about exercise now, at this late stage.
Sure, 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 sure. No, but you can, I'll send you the link for the exercises on the YouTube channel also. Yeah.
Yes. Thank you.
Any other questions? Please put your hand up. If you have to discuss a case, that's fine. Someone you have seen recently. Ajay, you got one more question, or your
Yes,
hand?
yes. Yes, I found my chat was disabled today. Is that what was meant to happen today?
Oh,
Because
I'm so sorry. No, I don't think your chat was supposed to be disabled. I apologize if it has been
oh,
disabled.
thank you. Because I could only put something in Q&A if I wanted, but the chat is disabled. I can see it now.
Oh,
Say it now.
oh, you can put it in Q&A, but you couldn't put it as chat.
Yes.
Right.
But
I don't know why, but I will check that. Yeah.
Thank you.
Anyone else? Hand, please feel free to put your hand up. Yeah, Jessica, please. Yeah.
Would you advise going to a gym for hip or knee problems, provided there was someone at the gym that said that, you know, they saw people quite often with those kind of issues?
Well, it, I wish there was an easy answer to that. There are two aspects to it. One is if there is someone to guide you, there is definitely a greater chance of success. Because, if someone is going to, I mean, it's just like, whether it is your son or daughter, or whether it's your student, or whether it is your colleague, your co-worker, you tell them you're amazing, you'll do well, I have every faith in you, they're going to do well. So same way, if you're a physiotherapist or doctor, you tell your patient, I have faith in you, do the exercise, you're amazing, you've done the exercise so well, they will do well. So one-to-one guidance, one-to-one encouragement, one-to-one motivation definitely helps.
Thank you.
But so if you go to the gym and there is a gym instructor or a personal trainer, yes, the chance of you doing the exercise is greater, the results are greater. But the difficulty when you go to the gym is you have to do all the exercise within an hour or hour and a half. Now, I do not know how successful that is. Whereas if you spread it during the day, it is much better. So if you do snack exercises, 5 minutes every hour, that is far. And if you're 12 hours in a day, you're doing it for one whole hour, because 5 minutes into 12 is 1 hour. That may be better than actually going and squeezing it. Because I tell my patients, use the traffic light system. The traffic light system is when it is on green, you exercise. There is no pain, you should exercise. When it is on amber or orange, then you're having discomfort, you need to slow down to come to a halt. But red light is you don't exercise, you stop. But red light doesn't mean you're parking the car, locking it and going away. It is not a parking space. It's only a temporary stop till the light turns green again and you have to start again. So so the effect of this snack exercise, doing 5 minutes every hour for 12 hours, is that you're doing little bits of exercise, but you're spreading out during the day. You're not making it too difficult. Whereas you go to the gym, you walk, you go on the treadmill for 20 minutes, it goes beyond your pain threshold. So you don't want to take your pain over the pain threshold. You want to come underneath the pain threshold, and by doing that repeatedly may be a better option. So yes, doing at home, but how to commit it? We are rolling out a program shortly whereby you can do exercises online. So we have, we have got a app based exercise which will actually monitor you. That may be better. So even at night, 1 o'clock, you wake up and you want to do a few exercises, you just have to on the app. But yes, it is technology dependent, but hopefully we'll be rolling it out in the next month or two. So I will keep you informed, and that will be a better way. So even at night, you have someone to, the app on the will guide you to do a few exercises. Yeah.
Yes, thank you.
Ajay, you still have your hand up?
Yes. So I think respectfully, I think 5 minutes an hour is just not practical, because, trying to even motivate people to do exercises once or twice a day is hard enough, but to do 5 minutes every hour, I think virtually impossible, really.
I take your point. I understand what you're saying, but surprisingly, I do not know the answer. Surprisingly, we tried to do a short, the rise, race, and thrive. We asked all older adults to sit and stand 5 times every hour, And again, when they sit and stand 5 times every hour, we also told them to take 2 1-liter water bottles and lift them up into the air and down. Now they are not going to the gym, but just these exercises are making them more active. And if you give 20 exercises and tell them to do, we know that people don't do, you don't do, I won't do. Whereas if you give them 2 or 3 exercises and tell them to do repeatedly, they're more likely to do it. And when they are making coffee, when they are boiling, watching the kettle boil, or they are cooking, little bit of exercise. Yes, it may not be every hour, but snack exercise over a period
Yes.
of time may be better. But I do not know. We do not have the real results of which is better. I'm not saying
No.
I'm right. I'm not saying you're right or you're wrong. Yeah, we
Little,
don't.
little and often is good, but maybe the 5 minutes an hour is too much. Maybe if you say like 2 or 3 times a day, if you do five
Yeah,
minutes,
yeah.
that's a possibility.
Sure. Yeah, I agree. I do not know what is the right dose. We have
Mm.
to try. But the biggest difficulty is motivating patients. Biggest
Yes,
difficulty.
yes,
And some people are so motivated they will do the exercises
yes,
even before you tell them they have done the exercise.
yes.
But some, I'm not being rude or inappropriate, but some patients from difficult backgrounds, very difficult to
Mm.
motivate them. There is no motivation in them to do exercise.
Mm.
How to get them to exercise?
Mm.
You know, very difficult. And they may be on benefits. They may be smoking. They have their diet is poor. How to get them to change? I wish I
Mm.
had an answer to that. I wish I really had an answer to that.
And going the other way, I saw a psychiatrist as a patient, and I gave him, a little bit of walking to do. So then he came in and he said he was in a lot of pain with his back and hip, I think. And I said, "So what have you been doing?" He said, I walk 5 miles every day. And I said,
Yeah.
"That's too much. That's too much." So he was an extreme case, you see.
Yeah. No, I agree. I agree. Yeah. Hannah, please. Yeah. Hannah, you put your
Mm,
hand up,
Yeah,
please.
yeah. Can you hear me?
Yeah, we can. We can. Yeah. Thank you.
Yeah. Okay. So I was just going to offer kind of my experience or add to what you've just said about the issue around motivating people to exercise. And I find that often I'm seeing people after they've seen someone else, been given exercises, but not engaged with the exercises, and then come to me. And I think often it's a case about tailoring the exercise to that person, understanding what's important to them, helping them find ways that they as an individual can incorporate into their day. But also it's about uncovering if there's any fear attached to the movement and reassuring around that, and going through the exercises with them enough so that they feel the benefit already, and that gains motivation already, and also helps them to feel safe to do the exercises. So I guess what I'm saying is, when I've seen people not engage with exercises because they've just been given the exercises like done to them without engaging them properly in the process of
Mm.
understanding the exercises.
No, you're completely right, because just giving the exercise is not going to help. It has to be an education plus exercise package, because they need to
Mm.
be educated why the exercise is important. You're completely right. Yeah. Yes,
Jessica
Jessica.
again.
Yeah. Please. Yeah.
It occurred to me from watching the slide that one way to motivate people might be to say that 44% don't need the operation if they've been doing the exercises. So just being given a specific figure, which is pretty high, might be enough to motivate some people because they feel there's a real point to it, because they may even be able to avoid an operation.
Yes and no. Again, the answer is mixed, because there are some patients who don't want an operation. Unfortunately, patients want to choose the way they want. Some patients don't want an operation. They will pick up on the 44 and will like to do the exercises. But there are other patients who desperately want an operation, and you tell them, go do an exercise. They say, "Oh, you want to save money, that's why you're asking me to do exercise. NHS this is an NHS ploy to not spend money on me." I try to tell them, no, it is going to make you better, do the exercise. No, you just want to save some money for the NHS. So there are two sides of the same story. So there are some, so it's people are, we need a huge input from, the center, from even from the political parties, that exercise is important, being active is important. It has to come from our fiber, deep within, that exercise is important. That unfortunately is not there. You go to Netherlands, you see the number of 80-year-olds who are cycling. How many 80-year-olds do you see cycle in UK? And road protection rules are much better in Denmark, all the the Nordic countries. Whereas here, you can kill a cyclist and you'll 400-pound fine. There is, so there's no protection. How many people cycle? You don't even have proper walkways, isn't it? I mean, there are cycle paths in London. It is changing, and some cities it is changing. We need, as the government, to put more effort into getting us to be more active and mobile.
Yes, I agree.
Good. If there are no more hands, we'll come to a close. Thank you so much for attending. Thank you for, you inspire all of us. And Sarah, anything for you to close?
Well, I think the questions have shown that you have made people think, that you've made people revise what they've had lurking away for some years and actually come to the fore again. And you've given us inspiration to exercise for the future and the value of exercise, which is so important. So thank you for all your detailed slides, all your excellent presentations and explanations. And we look forward to receiving the information from you, and also the link to the Arise app when it's ready, and to your next presentation.
Thank you. Thank you so much, Sarah. Thank you for all your inspiration and guidance. Thank you so much.
Thank you, and thank you on behalf of the college and all of those who've been with us this evening.
Thank you so much.
Thank you.
Bye.
Thank
Bye.
you. Bye.
Good night.
Bye-bye.
Bye. Bye.
Bye.